Hi everyone, this is Professor Stevens. Today I want to go over Chapter 24, which looks at not only fluid and electrolyte homeostasis, but also fluid and electrolyte imbalances. When we're looking at these imbalances in terms of fluid volume, we're going to be looking at excesses or deficits. In terms of electrolyte concentration, we're going to see whether or not we have hyper or hypo situations occurring. And in some situations, these fluid imbalances and these electrolyte imbalances have the potential to be fatal. For example, hyponatremia and both hyper and hypokalemia can be fatal as well. There are a number of different reasons that these things can occur, and in many cases, fluid imbalances are directly related with electrolyte imbalances as well, so you've got to keep that in mind. We're kind of going to be doing a bit of a brief overview through this chapter. There is a lot of material to go over in this chapter, and I actually will only have you focus on 3 of the electrolytes for right now. We're going to look at only sodium, potassium, and calcium just to try and minimize what you need to do. Instead of having a very brief bit of information on a whole bunch of things, I wanted to go into a little bit more detail about 3 of the major electrolytes. And then we've been talking about fluid off and on so far throughout the course, and so we're going to expand on fluid excesses and deficits a little bit more within this chapter. So if we look at how fluid is distributed within the body, we have to look at what's happening between the circulatory system and then the fluids in the other compartments within the body. And so what we're looking at in particular is how fluid is entering and leaving the bloodstream. And so what we have are 2 different basic types of pressures that we can use to determine fluid movement. We have hydrostatic pressure, which is basically the physical force of a fluid being moved from one area to another. So physically pushing a fluid in a direction. So picture like your blood pressure. As your heart is beating, it's physically pushing a fluid from one location to another. The other type of pressure that we're looking at is osmotic pressure, and this is based on changes in concentration. If you remember, osmosis is the movement of water. Diffusion is the movement of particles. And while we're concerned about movement of particles and diffusion when we're looking at electrolytes in terms of fluid balance, for right now, we're looking at osmosis. We're looking at what does water want to do. And remember, this is a passive process. This does not take any ATP to move water from one area to another, but it's going to take a little bit. You're going to have to kind of remind your brain about some of the things associated with concentrations, because sometimes it's easy to get diffusion and osmosis confused when you're looking at what things are moving. So try to see whether or not you're focusing on the electrolyte or whether or not you're focusing on what the actual water is doing. And so when we're looking at how things are moving in and out of the bloodstream, we're either physically pushing them out through hydrostatic pressure, or we're allowing things to move back in based on changes in composition, which is related to osmotic pressure. So capillary hydrostatic pressure is the physical force of blood pushing against the walls of the capillaries. This is like your blood pressure that would push fluid from the capillaries into the interstitial fluid. And then osmotic pressure can be found within cells, within the interstitial fluid, within the bloodstream. Here, the interstitial fluid, this is the concentration of the fluid in between the cells in the tissue spaces, hence interstitial. And so the concentration of that fluid determines how our particles and fluids will move within that particular space as well. And then within the capillary, we have to also look at osmotic pressure. This is going to be important for pulling fluid back into the bloodstream. And then finally, the pressure of the fluid within the interstitial space. How is that moving fluid into the lymphatic system, for example, as well as putting pressure back against the capillaries? So I threw this in here really quickly because I wanted to do a brief review for you guys to remind you that all of those words that you promptly forgot after leaving chemistry are back here again, that you're going to have to go and take a look at to determine how fluid is moving in and out of the body. And this is not just for this unit. This is a huge topic in nursing. This is probably one of the more challenging topics in nursing because you can potentially kill a patient by giving them the wrong fluid or electrolyte composition if you're providing intravenous solutions and things like this. So this is a topic that's going to keep coming back over and over again. So you want to make sure that you understand especially about hydrostatic and osmotic pressure. So I'm sure you've seen this before. If you have something like a red blood cell and you put it into a solution that has a similar concentration as to what's, as to what's inside the cell, that solution is going to be called an isotonic solution. Iso referring to same. So the concentration inside and outside of the cell is going to be the same. There is no net movement of water. So water can enter and leave the cell, but it's going to be at a rate that's going to be completely balanced. And so this is the way that most of our body fluids currently exist when we're not moving anything in and out. Notice there's nothing specific defined. It just says solute. We're concerned about the concentration, the amount of fluid and the amount of stuff. We're not worried right now about what the stuff is. We're worried about what's happening with the water. So keep that in mind. If you were to put that red blood cell into a hypotonic solution, something like distilled water, I guess this isn't distilled water because there's still stuff in it, but in a very dilute water solution, you can see that water wants to move from the solution into the cell. And so you can see that you have a net movement of water from the solution into the cell. The cell can swell, and in some cases could potentially burst as well. The reverse of that situation is if you were to put a cell in a very concentrated solution, like a very concentrated salt solution, for example. Then water wants to leave the cell, and you can see that the cell will shrink, and for red blood cells, for example, the membrane becomes wrinkled. That appearance is called crenation, or the cell is crenated. Not cremated, crenated with an N. And so the key here in understanding osmotic pressure is you have to know what is considered to be high osmotic pressure and what's considered to be low osmotic pressure. So when a solution is concentrated, that's the same thing as having high osmotic pressure. Versus a solution that is dilute has low osmotic pressure. And so in this hypotonic solution here, we can see that the solution is dilute and the cell is concentrated. So this means that if the cell is concentrated, then that means that the cell has high osmotic pressure. And the solution is dilute, so it has low osmotic pressure. I'm just abbreviating that OP for right now. And then if we did the same thing for the hypertonic solution, in this case, things are reversed. The solution is concentrated. So that means that the solution now is going to have high osmotic pressure. And the cell is dilute. It has low osmotic pressure. This is where you have to be very, very careful. Notice in each of these situations that water always moves from dilute to concentrated. Always. And this is not with any energy or anything, right? You can see it goes from dilute to concentrated. This means that water always moves from low osmotic pressure to high osmotic pressure. Be careful. This is different from diffusion. Diffusion, we're looking at the particles. Particles always go from high to low concentration. In osmosis, water moves from low osmotic pressure to high osmotic pressure. It's going to take a bit to think about it. We're going from dilute to concentrated, from low to high osmotic pressure. Okay, so just be very careful. This is a little counterintuitive, so you've got to think about it a little bit, because osmotic pressure works different from everything else. Hydrostatic pressure goes from high to low. Diffusion, high to low. Osmotic pressure is opposite. It's inverse. Water goes from low to high osmotic pressure. So just be careful. So if we look at this very crude diagram that I made to illustrate normal fluid balance, you can see that blood flow is going from the arterial end to the venule end. So here, blood flow moves in this direction. Of course, it went away by accident there. Blood flow moves from left to right in this figure. Remember, the blood's coming in at the arterial end under some pressure from your heart beating. You've got a pulse that's there, and so every time your heart beats, a little bit of fluid gets pushed out of the capillary into the interstitial fluid, because the cells that line the walls of the capillaries have spaces between them. This is how we get exchange occurring. So some fluid comes out with every heartbeat, but that's okay, because that's what's needed in order for this exchange to occur. So what happens when we push that fluid out here on the left side? There are a few different things that fluid is going to do. So it becomes part of the fluid that's in the tissues, the interstitial fluid. If the cells need it, it can move in and out of the cell by osmotic pressure. Notice it came out from the capillary by hydrostatic pressure, physically pushing, right? Heartbeat, nothing to do with concentration. This is due to your blood pressure. But in and out of the cell is going to be determined by whether or not the cell is going to need fluid or not. So that's osmotic pressure. And then what we did when we pushed fluid out of the bloodstream into the interstitial fluid, we pushed a fluid into a fluid. Well, that's hard to do unless you have a space for the interstitial fluid to go, and that's where the lymphatic system comes in. Remember, the lymphatic system is our drain, just like in a sink. It's draining the extra fluid away, and then it's going to filter it through our lymph nodes and then put that fluid back into the bloodstream. It actually goes back in through the right subclavian vein, predominantly. So I'm physically going to push that fluid from the interstitial space into the lymphatics. So that's hydrostatic pressure. And then we have to return some of that fluid to the bloodstream. And so it moves back into the venule end of the capillary through osmotic pressure based on the concentration inside the bloodstream. Because we lost a little bit of fluid here, so the blood's a little bit more concentrated. So osmotic pressure pulls that fluid back into the venule end. We can't push it in by hydrostatic pressure. There's no pump here in the cells, but it can move based on changes in concentration. So this is normal fluid balance, and you can see that I've had 2 arrows that come out and then the 2 arrows that drain away, so everything should be balanced. So when we look at controlling fluid within the body, we have to go back to those hormones that everybody loved from the first unit, aldosterone and ADH. And so if you remember ADH, antidiuretic hormone, this works to reabsorb only water in the distal convoluted tubule of the nephron. What this does, and go back to your notes from the stress response, it decreases urine output, which increases blood volume and causes us to increase blood pressure. That's what we were concerned about with the stress response. But here, we're looking at it in terms of fluid balance. So if we were dehydrated, we would want to increase our ADH, because then we would increase our blood volume and retain fluid. That makes our urine more concentrated. You know this, when you're dehydrated, your urine is a very dark color. It's got a very strong smell to it because it's very concentrated. ADH plays a role in helping to concentrate your urine to help with fluid balance. And then a side effect of that, of course, is associated with blood pressure. If, however, you alter ADH, so you can block it at its site of production or release in the brain, or you can block it in the nephron. So if ADH doesn't work, then what you end up with is a lot of very dilute urine being passed, and so that can actually cause you to become dehydrated. You know this if you have alcohol. Alcohol can actually block the release of ADH, and so as a result, you pee frequently and you can become dehydrated if you drink a lot of alcohol. And so if you look at the way that this slide is set up, at the top here causes reabsorption of water. This would be increased ADH here that's going to do this, right? So this is decreased ADH down in the bottom. So increased ADH, we reabsorb water, decrease urine volume, increase blood volume, all those things that we saw before. So just make sure you pay attention, because antidiuretic hormones sometimes can get confusing. So you just have to think it through a little bit. There are some problems associated with ADH. So if, for example, you damage the pituitary gland, you can have some issues related to the release of ADH. And so if you don't have enough ADH being released, so again, this is a decreased ADH problem with related to the pituitary gland, you can end up with a condition called diabetes insipidus. This is nothing to do with diabetes mellitus and glucose levels. The term diabetes means siphon. It refers to the fact that it makes you pee a lot. And so in diabetes insipidus, you're going to pee a lot because you don't have enough ADH. So even though the word diabetes is in there, it's not at all related to diabetes mellitus. Totally separate disorder. Aldosterone, its job, remember, is to reabsorb sodium. And so when you reabsorb sodium, sodium is an ion, water comes along with it. And so this also increases our blood volume and increases our blood pressure, like we saw with the stress response. But it also is going to decrease our urine output as well. It does it differently from ADH, obviously, because it's working with sodium. And so you can see if we have more aldosterone released, then that means less urine. And when we decrease aldosterone, we can excrete more urine. So we can also use aldosterone now to control our fluid balance. The natriuretic peptides, ANP and BNP, work opposite to aldosterone. Aldosterone is a steroid hormone, and it's pretty strong. These guys are peptide hormones. And so while they are effective at what they do, and they're related to blood pressure to some degree, you can see ANP is from inside of the heart, BNP also inside the heart, but in the ventricles as well. So I can remember A goes with atria. These guys are minor components associated with fluid balance because they work opposite to aldosterone. Notice natriuretic, natrium. This reflects the actual name for sodium, right? The chemical symbol is Na, natrium. So natriuretic peptides are related to sodium as well. That's why they're linked with aldosterone, but they do the opposite effect of aldosterone. So just briefly, I have you look at the natriuretic peptides, but I want to make sure you go back and review ADH and aldosterone. So I have you go through and look at the effects of having low blood volume, or sometimes it's called uncomplicated extracellular volume deficit. These causes, if you think about these, remember, you're doing this test as a multiple choice test predominantly, right? And so these are not going to be matching or anything like that. That could get crazy because there's so much overlap. But what I want you to be able to do is to go through these different causes and see if you understand why they're going to cause the problems that they do. And most of these make sense if you think about it. Emesis. Emesis is vomiting. Well, of course, if you vomit for a long period of time, you're going to end up with a volume deficit. That makes sense. But some of these are going to take a little bit of thinking, and they may require you, looking up some vocab words, for example, like paracentesis. You might have to go and look up what that word means if you're not familiar with that procedure. But other things are going to require a little bit of thinking. Okay, if I have a very bad burn, like the last item here on the list, remember your skin is meant as a protection for your body, but it also helps resist dehydration. If I have a very severe burn, especially over a large area of the body, I'm running the risk of being dehydrated because I lost my barrier that helps keep my fluid in. The skin has a huge role in keeping you from being dehydrated. So a severe burn can cause you to become dehydrated. So I want you to go through these lists that are here for the causes of the volume deficit and excess and make sure you understand why each of these could cause that. So if I gave you a question that said, which of the following could lead to an uncomplicated extracellular fluid volume deficit, or basically volume loss, you read through that list and go, okay, yeah, if I used a diuretic, I'm going to pee a lot, that could make me dehydrated. I know what that means. So I want you to go through and look up the components of this table and make sure you understand why each of these things could lead to fluid loss. So again, going along with this, you have to look at the manifestations of ways you could tell when someone's had a volume deficit. And these things make sense if you think about it, right? Sudden weight loss. If you've had vomiting and diarrhea for a while, then obviously you're going to become dehydrated. That can cause you to lose weight. If your blood volumes is low, then your blood pressure is going to be low, which means your veins are going to be flat. Things like this makes sense. So you can think about what the manifestations are if your volume is going to be low. So you can think about these things as to what's going on in the bloodstream, what's happening in the cells of your tissues, and you can understand why these manifestations are going to occur, especially if you've ever had a period of time when you've been severely dehydrated, then these things will all make sense to you. In terms of fluid excess, again, some of these things take a look through and make sure that they make sense. So if you gave too much IV fluid, of course, that can cause a problem. And then you have to look at some of these other things and kind of think through a little bit, why are they causing too much fluid to accumulate? Primary hyperaldosteronism. Well, if I have too much aldosterone, I retain too much sodium in water, I'm going to have too much blood volume, right? That makes sense. Heart failure. We talked about heart failure is a congestive problem. You get fluid collecting, So go through each of these things and make sure that you understand why they cause fluid to collect. And again, when you're looking at the manifestations, think about what's happening in the tissues and the bloodstream that would cause these signs and symptoms to occur. If I have increased blood volume, I would expect my blood pressure to be up. My pulse is going to be strong, bounding. I'm going to be able to detect it really easily. I may even see distended neck vein, distended jugular veins, like you would have seen in right-sided heart failure, for example. Fluid in the lungs, so crackles might be present, things like that. So go through the manifestations and make sure that they make sense to you about why this would happen if you have excess amounts of fluid in the body. Then you get into the section on the electrolytes. And again, this can get to be overwhelming. So, just make sure, be careful, because, you're going to see some connections between fluid imbalances and things associated with sodium as well. So just pay attention as you're going through. When you're looking at concentrations of body fluid, we're looking at, in some cases, what's going on with the electrolytes, and then in other situations, we're going on with what's happening with the sheer amount of fluid that's actually there. So this is where sodium is going to come into play as well. So hyponatremia is one of those potentially life-threatening situations. This is sometimes called water intoxication because it can happen from drinking too much water very quickly. And so your sodium level drops very, very low. It's important to go back and look at what the normal functions are for sodium in the body. Why do we need sodium? For example, sodium is very important for the sodium-potassium pump, which is especially important for nerve impulse conduction. You're going to get a whole lot of tables and boxes that are going to give you the causes and manifestations associated with these electrolyte disorders. Again, look through, and if you can understand why these things occur, then you'll be able to pick out what the problem's going to be when you see these sort of things on a test. So excessive ADH. If I have too much ADH, I retain too much water, that's going to dilute my sodium concentration, and my sodium concentration is going to come out as being too low. The same sort of thing. Excessive beer ingestion, near drowning in fresh water, those sort of things where you have more water that you're taking in than salt, right? The second set of causes happens if you are losing salt faster than you're losing water. So if you took diuretics, for example, and it caused you to lose a lot more salt faster than you would lose water. Things like that. If you had fluid replacement, where like after a marathon you drank just straight water instead of something like Gatorade to replenish your electrolytes, you can put yourself in hyponatremia. So just make sure you understand why each of these could cause your sodium concentration to be low. And then when you're doing the clinical manifestations, remember these relate to what the functions are for these ions in the body. So I told you that sodium is important for nerve impulse conduction. So of course you would expect to see problems with the nervous system functioning if you don't have sufficient levels of sodium. So you can see things here like malaise, anorexia, nausea and vomiting, for example, and then this can progress into very severe symptoms because, like I said, hyponatremia is one of those potentially life-threatening electrolyte imbalances. Hypernatremia, we have too much sodium, or we don't have sufficient amounts of water that can happen. And so again, causes for hypernatremia, we either have too much salt and not enough water, or we've lost excessive amounts of water, causing our salt concentration to be too high. So go through and take a look at what can lead to those different things occurring. You can see under the loss section, there's diabetes insipidus, where we don't have enough ADH. So very insufficient amounts of ADH cause us to pee a lot. That can cause us to lose a lot of fluid, and then it would cause our salt concentration to go up. No access to water, so if you're stranded in the desert, for example, that would be an example of not having access to enough water, causing your sodium concentrations to be high. So just make sure that you understand those causes. And then manifestations, a lot of these are very similar to what you would see if you're dehydrated, thirst, oliguria, very low urine output, and then hypernatremia, when it's very severe, also has the potential, obviously, to be life-threatening as well because of its implications related to dehydration as well. So then it goes into a little bit more about dehydration as well, where we're combining the fluid loss as well as the problems with having high levels of sodium as well. It goes through and gives you causes associated with dehydration, and some of these you're going to see an overlap with fluid balance as well. So again, just think about, okay, if I have excessive vomiting, I'm going to have trouble with my fluid levels as well as potentially with my electrolytes as well. Same thing we mentioned with burns earlier. Extensive burns, obviously we can lose a lot of fluid as well. And then it gives you a lot of manifestations associated with clinical dehydration. Read through them. They're going to make sense. You've already gone through a bunch of these with fluid volume deficit, and then this adds in some of the other things associated with hypernatremia as well. So you'll see these things go hand in hand. So don't panic. When you start to read through, these things will make sense, especially fluid and sodium are pretty straightforward. Effects of dehydration, you're going to look at some of your blood work values, right? Remember hematocrit, the proportion of red cells in a blood sample. If you have low fluid, then your blood cell amounts are going to seem higher. So your hematocrit levels are going to be increased, and your electrolytes in many cases can be increased as well. Your urine output tends to be low, and then it tends to also have high specific gravity, which we'll talk about when we do the kidney as well. That means that it's very concentrated, there's lots of stuff in it, and so it tends to be a little bit heavier. Then we get into edema, which is kind of the opposite of dehydration. And there are 4 basic causes for edema. And so what I did was I outlined each of these causes for you, and then I'm going to put back in here for you the normal fluid balance to show you where that particular problem is occurring. So the first cause of edema is what happens if you have high capillary hydrostatic pressure. So this can happen whenever blood backs up in the body, like with heart failure, or it can happen with uncontrolled high blood pressure. So that excess blood that's collecting in that area because of heart failure or because of high blood pressure causes more fluid to be pushed out faster than the lymphatic system can take it away. So if you look here, this is our normal picture that I had done for you before. So what's happening in this situation is we now are pushing out more fluid at the hydrostatic end faster than it can drain away. So here I've increased the number of arrows. Remember, edema is collection of fluid in the interstitial space. So the fluid's collecting here faster than we can take it away. So over time, we can get edema developing in the tissues in that area. So if it was high blood pressure, this could be throughout the body. If it was right-sided heart failure, that fluid collects in the legs and the feet. If this was left-sided heart failure, that causes fluid to collect in the lungs. So wherever you get blood collecting in that area due to backup with heart failure or with high blood pressure, it's going to push that fluid out. The second cause is increased capillary permeability. We saw this already because this happens with inflammation due to the release of histamine. It makes the capillaries leaky so that more fluid can come out, and we know that edema is one of the local signs of inflammation, and so that can help immobilize an area, for example, that's been injured. So if we go back to our normal fluid diagram, this would be equivalent to us putting little openings in the capillary so that we have little bits of fluid come out as a result of histamine, making these little pores bigger in the capillary. So fluid comes out again faster than it can drain away, so it causes edema to occur. Typically, we don't see this happen throughout the entire body. You don't get edema all at once because of histamine throughout the body. Edema is usually a local inflammatory reaction, but it's still, this is one of the causes for edema to develop. Again, more fluid out of the bloodstream faster than it can drain away by the lymphatics. The third cause here is blocking the drain or blocking the lymphatic system. So this could be for some reason you've had some trauma or injury, so the lymphatic system is damaged, the vessels are damaged, or maybe you've had surgery and the lymph nodes have been removed, like that can happen after a mastectomy. They can remove the lymph nodes in the armpit, for example, or maybe they're clogged, full of material, because they've been busy fighting off infection or something to that effect. Anyway, this is equivalent to having a clogged drain in your sink. So as a result, you can't get drainage occur. So the same amount of fluid is going to come out of the bloodstream, but we can't drain it away. So in our fluid diagram, this is equivalent to us basically blocking this part here, blocking hydrostatic pressure from happening. So the lymphatic system doesn't drain everything away, so over time, fluid begins to collect in that particular area because we don't have the drain present anymore to take that fluid out of the area. Our last situation is the one that takes a little bit of thinking because it goes back to osmotic pressure. Loss of plasma proteins or low capillary osmotic pressure. Loss of plasma proteins can happen for a couple of different reasons. And we're going to look at each of these in some subsequent units. So in kidney disease, in kidney failure, the plasma proteins are lost in the urine. So that's the first way that this can happen. The second is if you have liver disease, then you have decreased production of plasma proteins. And the big one that we're most interested in is albumin, which is made by the liver. And the job of albumin is, there's many functions to albumin in the body. It can be used for lipid transport and all sorts of things, but it also is important for maintaining fluid balance. So these guys are present in the bloodstream to keep it from becoming dilute, because when blood is dilute, you can't put fluid back into it through osmosis. And so as a result, fluid stays behind in the tissues. So in kidney disease and liver disease, you can end up having fluid collect in the tissues throughout the body because the bloodstream is dilute, either because in kidney disease we lost the proteins in the urine, or in liver disease we didn't make them in the first place. And so we have decreased albumin levels. And so if we go back to our figure, the problem in this situation is happening here. We can't return fluid back to the venule end through osmosis because our blood is too dilute. We don't have plasma proteins in there. And so that would be like going from concentrated to dilute. That doesn't happen, right? Remember we said water always moves from dilute to concentrated. And so here we can't put fluid back in, so over time it begins to collect in the interstitial space and lead to the development of edema. So those are the principles behind fluid balance. And then the remainder of this chapter goes over the electrolytes components. And we already sort of went over sodium very briefly. And so I just want to highlight for you some of the things to think about with the other two electrolytes that I wanted you to know, with potassium and calcium. Not that the others aren't important. We're obviously going to be talking about bicarbonate when we do acid-base imbalances, but I wanted you to know some of the electrolytes more in detail than just barely knowing anything about all of them. So our electrolyte imbalances are either going to be obviously excesses or deficits, and you've got to think about, are we taking in too much? Are we losing them? How are they coming into the body? Where are they leaving the body? You've got to think about, how are they coming in and out of the bloodstream, right? Because what we're talking about, all these words end in emia. We're looking for how are we changing the concentration of these electrolytes in the bloodstream. So you've got to think about, first of all, are these electrolytes normally higher in concentration in extracellular fluid, or are they higher inside the cells in intracellular fluid? And then look at the routes in which they can be moved in and out of the bloodstream. So I just want to highlight for you each of the remaining imbalances with potassium and calcium. So for hypokalemia, here's the box associated with the causes for these. And so again, I want you to look through this list and make sure that you understand why each of these different components can lead to low potassium levels. Obviously, things like diet, anorexia, and fasting, and all those sort of things. If you don't eat enough, your potassium levels are going to be low. But some of these are going to take a little bit of thinking. So, for example, alkalosis, metabolic alkalosis especially. Hydrogen ions and potassium ions have an interesting relationship. And so when hydrogen ions are low in the bloodstream, to balance those out, we're going to move potassium. And so potassium is actually going to leave the bloodstream as well. And so as a result, when you have metabolic alkalosis, you can generally expect hypokalemia to be present as well. And then things like excess insulin can also deplete your potassium as well, can move it into different areas as well. If you look through, hyperaldosteronism is in here again. This is because aldosterone retains sodium, but it also gets rid of potassium. Sodium and potassium have an inverse relationship. When sodium is high, potassium is low. So you've got to look at some of these things. Cushing's disease causes too much aldosterone to be made. Corticosteroid therapy can include, corticosteroids are aldosterone and cortisol. Again, corticosteroid therapy, Cushing disease, and hyperaldosteronism are all related to the same thing as well. And so you can take a look through why potassium levels might be low. Potassium is also important for nerve impulse conduction and is especially important for muscle functioning, and especially in the heart. And so you can start to see when potassium levels are low, there's a lot of abdominal effects associated with the digestive tract. You're going to see muscle weakness occur throughout the body without having insufficient potassium levels, but this also has major implications on the heart. It can cause cardiac dysrhythmias and can actually lead to sudden cardiac arrest by not having enough potassium. And so make sure that you go through and you take a look at that as well, because this can also be potentially life-threatening. Hyperkalemia, too much potassium. Again, look through this list. You can see that some of these are obviously opposite to what you just did in hypokalemia. So there's acidosis, for example, not enough insulin, things like that as well. And then you can go through and sort of match up some of these things to go along with hyperkalemia and what the natural function is for potassium in the body. Again, this is going to see effects in the same areas of the body, but some of them can be a little bit in the reverse, so you might get some more cramping associated with this. You can get muscle weakness occurring as well here, and this also causes cardiac dysrhythmias. Too much potassium can lead to cardiac arrest. This is why it's used as one of the euthanasia medications in many cases. An injection of potassium chloride straight into the heart will stop it. Too much potassium actually causes the heart to relax too much, actually, and so it doesn't pump at all, whereas not enough potassium causes it to contract too much. It doesn't relax, and so it can never fill. And so hyperkalemia, too much potassium, can be used to actually stop the heart. So you'll see that the manifestations between hyper and hypokalemia are very similar to each other, and potassium has to be kept within a very narrow range. It's one of those that you need to watch very carefully because of its influence on muscle function and heart function. For calcium, you've got to look at a couple of other factors that aren't associated with sodium and potassium at all. So vitamin D, remember, is necessary for absorbing calcium. Vitamin D is made in the skin and activated by the kidney. So if you have skin issues, you're not getting enough sunlight, or you have kidney problems, you're going to affect vitamin D, which is going to affect your calcium levels. Vitamin D is also a fat-soluble vitamin, meaning if you have any problems with digestive disorders that prevent you from absorbing fat, then you're going to also have problems with calcium as well because of the vitamin D issues. So that's why you see some digestive disorders associated with this as well. Calcium levels are regulated by a few different hormones, but the one that is associated with raising calcium levels is parathyroid hormone. And parathyroid hormone pulls calcium out of bones. It activates vitamin D in the kidney to help you absorb more calcium from your intestines. And so if I don't have enough parathyroid hormone, I have hypoparathyroidism, that's going to cause my calcium levels to be low as well. So you'll see some of these things appear. And then manifestations. Calcium is used within the muscle, especially for muscle contraction. And so you can see, you can go back and look in your anatomy and physiology book to see where calcium is actually used for muscle contraction, but you can see that you get a lot of spasms and cramping associated with hypocalcemia. Make sure you look up what Trousseau sign and Kvostek sign are associated with hypocalcemia. You can see muscle spasms, tetany throughout different parts of the body as well. And then hypercalcemia, too much calcium, still related with vitamin D and parathyroid hormone, but it can also be elevated for other things, right? We saw, for example, in multiple myeloma with the bone tumors pulling calcium out of the bones, your calcium levels go up as well. It can happen if you have any period of time that you're immobile, osteoporosis, things like that, pull calcium out of the bones, cause the same sort of manifestations to occur as well. But here now, with having too high calcium level, it actually causes muscle weakness. Low calcium causes muscle spasm. High calcium causes muscle weakness, problems with reflexes and things like that as well. So it goes through and gives you the manifestations to compare those as well. So don't get bogged down in the details. There's a lot in this chapter. If you know the basic functions of these ions and you can go through and say, hey, I know aldosterone's related to sodium and potassium, but not calcium, then you'll be able to pick out on the test, what sort of things are going to apply. Oh, parathyroid hormone, that's with calcium. That's not for sodium and potassium. Oh, if I have increased blood volume, that could be ADH and aldosterone. That's fluid excess. Things like that. Make sure you understand, because you have multiple choice questions, so you'll be able to evaluate each of the answers. The questions coming from this particular chapter, I can tell you, there aren't a lot. And so don't spend a tremendous amount of your time focusing on this particular chapter, because it's only going to be a few questions from this. The majority of what you're going to get for this unit is going to come from the respiratory system disorders.